All right, well, good morning, good afternoon, and good evening. Thanks for joining our marketplace session. At last, the secret to having an adolescent centered environment is revealed. My name is Shannon Rao, and I'm with JSI, a public health consulting firm, and my co presenter is Val. Val, would you like to introduce yourself?
Thanks, Shannon. So my name is Valerie Gavrilla, and I work for AHI as a program specialist. And just a little bit of background, AHI is based out of the University of Michigan, and we provide training, technical assistance, and coaching to healthcare centers across the country to make their environment more adolescent friendly.
Great, excellent. Well, thanks, Val. So we want to get just started, so we want to stay on task. So in the chat box, please answer the following question. What does an adolescent-centered environment mean to you? So you can just go to your chat box, type a few responses. So I'll ask the question again. What does an adolescent-centered environment mean to you? I see one person has responded so far. Centering adolescents' voice, rights, and participation, adult-youth partnership, an environment that's welcoming, comfortable, accessible to adolescents. Great, these are excellent responses. Welcoming to adolescents, a place where adolescents are wanted and listened to. Great. Non-judgmental, that's a great response. And comfortable with an adolescent environment, an environment that prioritizes adolescents' well-being. Excellent, great response. Great. Oh, we see a whole bunch coming in now. I love it. Adolescents can access accurate and reliable information in a way that they feel more comfortable, most comfortable. Environment where adolescents can explore, lead, and define what they want to be. Great. Adolescent-friendly environment, exactly. That's what an adolescent-centered environment means. So thanks for those responses. You can still go ahead and chat those in if you'd like. What we'd like to do now is we really want to hear from the youth themselves on how they define an adolescent-centered environment. So we're going to show the following video. It's only a couple minutes long, and Val's going to go ahead and show that video, and then we'll come back for some follow-up questions.
Hi, I'm Julie.
I'm Brandon.
I'm Clara.
And I'm Felipe.
We're here to talk about some ways that health centers can meet the needs of teens and young adults through things like physical space, policies, and personal interactions.
There are tons of ways to help teens feel welcome. Here are some of our ideas.
For some of us, getting to appointments can be challenging.
Having bike racks outside can make it easier for when we don't have transportation.
Posting hours outside your clinic is important, and make sure you have times after school hours so students can get there too.
It can really help some of us with unpredictable schedules if you accept walk-ins.
And if we happen to run late for an appointment, please try not to make us feel like we've broken the law.
The more comfortable we feel, the more we'll want to come back, which will help us get better health care.
Your waiting room matters. It's our first impression and a place where your teen patients will have to, well, wait. But hopefully not too long.
And waiting means sitting, so why not have comfortable options for all shapes, sizes, and ages?
I know doctors' offices are for little kids, but they're for teens too.
Why not show a diversity of styles and types of artwork?
And maybe even feature some pieces by local teen artists.
I'd like that.
Real plants are great too, but if they don't look taken care of, it makes me feel like I might not be either.
Magazines are standard in any waiting room, but why not have some that are geared to teens, like 17 or Electronic Gaming Monthly?
No, I want Mad Magazine or J14. Or Wi-Fi. I'd like the Wi-Fi password posted even better.
Hey, what about magazines in other languages? Y servicios de traducción en otros idiomas sería aún mejor.
Yeah, also show that the space is safe and inclusive of LGBTQ plus youth, such as a rainbow sticker on the door.
Teens can have pretty different interests, but one thing that matters to all of us is privacy.
Definitely. Having some kind of dividers at the reception counter can help keep us comfortable when we share private information.
I've even been at a place that had a white noise machine to make it hard to overhear.
As much as we love the reception area, we're really here to get into the exam room.
Of course we expect it to be clean and professional, so what matters most is our interaction with our doctor.
This means we're getting good eye contact, non-judgmental listening, and welcoming body language.
Having your confidentiality policy clearly posted in the room really helps us feel comfortable being honest.
And so is doing check-ins throughout our appointment to make sure we're on the same page.
Remember, not all situations are the same, and not all teens are the same. When in doubt, ask us.
All right, so that was a video made by AHI in conjunction with their Teen Advisory Council. So after viewing that video, I just want everyone to put in the chat box, what was something that surprised you, or did you learn something new from that video? So just your initial reactions, if you could share that in the chat box. Interested to see what people thought. Yes, I see someone said the little things matter. Absolutely. So we saw examples of like the plants being well taken care for, and how, having like an office plant that doesn't look like it's being watered, like how someone may think, well, if they can't take care of this, like how are they going to take care of me? Again, like the Wi-Fi password, even like having something like the Wi-Fi password shown to adolescent patients, like, okay, it's making them more comfortable. And like, okay, I can at least, spend some time on my phone. I'm in the waiting room. Magazines in other languages. Yes, absolutely. Having the inclusivity there. I see some other great things. The privacy screen and white noise machine stood out. Yeah, so like having that privacy, at least like, if we can't provide complete privacy, that illusion of like, okay, there's a screen, there's some white noise, something to make them feel like their privacy matters. I see some great.
I'm sorry.
Yep.
And there was a question about, in reference to, yes, it seems very centered around the youth in the U.S. Absolutely. This is based in the U.S. and the Western world. So we don't totally understand that some of these needs might not actually resonate with other contexts and other countries. And so that's something you also want to keep in mind is in the country that you work in, it might be different. And so so it's really important to really identify the youth that you're working with and really get from them specifically what's going to work and what's not.
Great point, Shannon. Thank you so much for pointing that out. Yes, it's all about talking to the youth in your area and see what works best for them. Absolutely, if this is not applicable, for sure. So then also, I'm going to move to the second question, which is when working with youth, what are some other challenges you can think of that maybe you experience with youth in a healthcare setting? So this would be challenges that maybe you've encountered or is like pretty common in your field. So again, if you want to just put that in the chat box as well. So someone that says the age gap. Yeah, so maybe not being comfortable with adolescents, or having that little disconnect there. They're in a kind of transition time of their lives from being dependent to independent. Hard to get them open up and talk. Yeah, so creating spaces where they are able to open up and talk about some sensitive topics usually come up in, healthcare settings with adolescents as well. I see some other great responses coming in. So getting to and accessing a health facility. Yes, absolutely. So access is a huge thing. Again, talking about in the US, some adolescents, at 16 can have their driver's license, but not all adolescents will. Still relying on parents to take them to healthcare appointments. Access is definitely an issue for sure. So these were all great responses and really aligns with what we found as well. So when AHI was doing some customer discovery work in our early years, we went out and asked healthcare providers in the field, what's your biggest challenge with working with adolescents? So some of those things that you just mentioned are on the screen too. So, hard to get adolescents in the door and the time with them is limited. The healthcare environment's not focused on the adolescent population usually. Providers are unfamiliar with the confidentiality laws or uncomfortable with the adolescent population as well. And it's just limited professional development opportunities. So all of this comes with the missed opportunities for providing patient-centered care and impacting adolescent patient outcomes. So what we did at AHI is that we took all these barriers and common problems with adolescents, and we made an intervention. So the result of that intervention to help address these issues was the Adolescent Centered Environment Assessment Process, or we shorten it to call it the ASAP, because that's a mouthful. So this is a comprehensive tool And it covers 12 key areas of adolescent health, which you can see those areas on your screen. And this is just one part of a larger quality improvement project that spans 18 months. And it includes things such as data collection, pre-post intervention materials, some trainings. And the great thing about this is that it's really customizable to the health center, so that when a health center goes through this tool, they pick out what's most important to them, known as priority areas. And then they work on those priority areas over the course of those 18 months. So now that I told you a little bit about the background, I'm going to toss it over to Shannon, who's an ASAP coach, and let her tell you what it's like to be an ASAP coach in this process.
Thanks, Val. So through Grant, I was able to become a coach with Adolescent Health Initiative. And so as a coach, I facilitate the ASAP tool with the identified ASAP team from the health center. So this usually takes about 2 hours to conduct virtually. So it's done at the beginning as it's a baseline that we do at the beginning of this 18-month process. And then I take that actual ASAP tool and customize the implementation plan. And this is really based on the priority areas that the health center has identified and who is responsible and target date to meet that priority area. So again, like I said, this is done at baseline and at year end. So throughout that whole 18-month process, part of my role as being a coach is I also do check-in calls periodically. And then I provide any additional technical assistance and support to really optimize the improvement process. So you can see that we spend quite a bit of time, with that specific health center to really help them identify those priority areas and meet the goals that they want to meet to become an adolescent-centered environment. So at this point, what questions do you have? And feel free to ask those questions in the chat box.
Mm-hmm. And I do see that we had a question about sharing the YouTube video. So I am going to put that YouTube video in the chat right here. And I did see that someone asked about sharing the tool. So as we said, this tool is part of a larger intervention. So it's not just a tool that we share. It's actually, it comes with, coaching and personalized coaching and other data collection tools. So it is a fee-for-service program that AHI provides, just for FYI. That is one of the interventions. But we do have some free resources that we're more than happy to share. And that's actually on the next slide after the question. So we'll get to those too as well. And I do see that someone asked, which locations and contexts is this tool used? So that's a great question. So we use this in primary care and school-based health centers. So we actually have two versions of the tool. And primary care looks like really different. We can use it in a lot of ways. We use pediatrics offices, family medicine. We do some family planning clinics as well as just like STI clinics we've done this tool in, health departments. It really is anywhere the adolescents are getting care, this tool is applicable.
And Val, there's a great question about, as far as how are youth clients engaged in the health assessment? Great question.
Yeah, and that's actually part of the data collection that we have is youth surveys. So we measure adolescent satisfaction with their health center pre and post this intervention. And really, we ask those questions about, how comfortable they feel, their interaction with the provider, if they know what health services that they can get without the parents' consent, which is a huge thing for youth of knowing what services are available to them as well. So yes, youth are definitely involved in at least the data collection. And then there's also a lot of indicators that are about adolescent input into center, as well as forming a youth council could be items that someone works on in the context of this intervention.
And then excuse me, there's an echo in the background. But has this been tested in low, middle income income countries context, like low and middle income countries?
Right. So this has not, it's only been used in the US for sure, for right now. So only in the US. But that's something that, if you were interested, maybe contacting AHI and seeing what we could do to kind of customize it to your needs for sure.
And that's one of the reasons why we're presenting it today, because we know that this has been focused in the US, but we want to really think about how we can expand this. And so that would be great if some of you are interested, to really contact Val and see what the next steps would be to something that we could adapt and implement in other countries, especially low, medium income settings.
Mm-hmm. Yes, absolutely. So if you're interested in this tool at all, feel free to reach out to me at AHI in general. We can kind of walk you through what that looks like and how to implement this in your setting for sure. So I know that we only have 3 minutes right now, so I do want to get to the next couple slides as we have our contact info, which you can continue to ask me and Shannon questions about this for sure. But real quick, like I said, so the ASAP tool, there is a fee associated with your health center going through that, but AHI has a lot of free resources on our website. So we have our website listed at the bottom of the screen that says adolescenthealthinitiative.org. So we have material such as starter guides, which are kind of mini toolkits that you can just download and use to help you in a lot of different adolescent-centered environments, such as like LGBTQ resources, as well as, being youth-friendly. We have mini trainings that you could do with your health center that are free, downloadable, and they're like ready to go. So you could present this at a meeting tomorrow if you wanted to. We have the script and questions and PowerPoint slides already set for you. We also have lots of webinars and trainings available for you as well that are free on our website that you can either watch a webinar or go through your own training, like clicking on a web-based module. And we have health center materials that you can contact us and we can send you posters or other materials that we have, which is really cool because a lot of those are actually made by our teen council. So it's for youth, made by youth, which is a huge part of what AHI does. And then lastly, just real quick, if you're interested in adolescent health, we do have our conference coming up in May this year. It's virtual for the first time ever, as we're all kind of used to this Zoom meeting first ever, virtual spaces. So usually we have about 400 attendees from all over the US. And sometimes international guests as well, but this year we're really hoping for more and an international audience. And so since we have the accessibility with being online this year. And we have a really broad range of attendees from behavioral health, primary care, research, et cetera. So it covers all areas of adolescent health. So registration opens in February, and you can also find out more info on our website as well. And then let's see, for the last slide, again, if you, I know that this was a really quick presentation today. So you just had, Scott to show a little bit of the work that we do, but if you're interested in learning more, feel free to contact me. My name is Valerie Gavrilla. I work at the Adolescent Health Initiative, or Shannon, who works at GSI, but is an ASAP coach as well. And feel free to look at our social media or our website to learn more about the work that we do. We'd be more than happy to answer any questions that you may have.
Yes, thank you so much, Val. I think let's see if there's another question. We have, I think, 1 minute left. Are there any unmet research policy questions one could explore?
I think the answer to this is probably indefinite amount of research and policy questions for sure. If we could narrow that down to what that looks like, we're always, at HI, we're always looking for more grant funding to make more resources and kind of tackle those problems. So of course, there's definitely more to explore that we could partner with and work with for sure as well.
And thank you so much for everyone for participating and answering questions and asking questions. And hopefully this might trigger something for you as far as maybe having something like this within your setting. So thank you so much and enjoy the conference, and we'll just turn it over to the next set of speakers.
Thank you so much.
Thank you. Good morning and welcome everybody. My name is Vincent and I'm from Save the Children. So we are making a presentation on developmental science programming with VYA. So I'm just trying to start sharing my screen right now and just do a quick introduction for our presentation today. So I'm making this presentation with my colleague, Christine, from University of Berkeley, California. And the presentation is built off a developmental science guide that was developed between University of California, Berkeley and Save the Children. So what this guide does is it just provides some basic understanding with some key learning and developmental needs for very young adolescents. So I hope at the end of this presentation is that you're going to see what it is you can pick and apply during your design and implementation of your different programs. So the way we have structured our presentation is that at the end of it, We're going to have a Q&A, so you can ask your questions or we can answer the questions you have. But to make it even easier, given the limited time we have a Google link, which my colleague is going to share in the chat box. So you can post your question there, and then we'll be able to get to those questions, read them out, or simply put them in the chat. We'll find out how we can track that and just read out some of those questions. Welcome to our presentation once more. I just hand over to my colleague, Christine.
Thank you, Vincent. So as Vincent mentioned, this developmental science resource is a product of the Discover Learning Project. And Discover is a Bill and Melinda Gates funded adolescent youth sexual reproductive health project. And it's a developmentally informed project for 10 to 11-year-olds in Tanzania, where the principles of developmental science were used in the creation, implementation, and evaluation of the project. And so this project, in its fourth and last year, aims to promote gender equality, positive relationships, and social emotional identity learning to enhance health, well-being, and sexual reproductive health outcomes. And so what is developmental science? It is the study of patterns and processes of changes that happen as a person grows and matures throughout their life. And if we leverage these scientific insights on developmental science, we can improve the design, implementation, and evaluation of VYA, SRH, and gender programs. And so developmental science can add precision if we match the appropriate intervention to the trajectory or inflection point of a developmental stage, and this can maximize outcomes. So why do we focus on very young adolescents? So very young adolescents is a window of opportunity, and developmental science suggests that there are 4 key reasons why early adolescence is an important time for interventions that can influence the life path. And I think the slide, we went forward a slide too far. But so these 4 points interact with each other, the ones that you see on the slide, and learning that occurs in this developmental window can influence these dynamic interactions and thus change the trajectories. So early adolescence is a time of important transitions and trajectories and inflection points. Inflection points can be social, such as switching or leaving school, or having a first romantic relationship. They can be cultural, such as observing a rite of passage marking the beginning of adulthood, or it can be physical, such as developing secondary sex characteristics. So understanding the pathways and the transitions can inform the design of interventions, the relevance of health messaging for young people, and the metrics for evaluation. And delivering these interventions at key times can increase their impact, address past deficits and traumas, and better position young people for the future. So early adolescence is also a time of changes that are happening in the brain, the body, and biology. So it is a period of rapid physical growth that is probably second only to infancy and early childhood. Young people are changing in their physical appearance, they're developing secondary sex characteristics, they increase their nutritional and sleep requirements to support this growth, and the same hormones that are stimulating this physical development also contribute to changes in the structure and function of the brain that influence the way that young people think, feel, and act. And so as very young adolescents transition from childhood into adolescence, they seek out new experiences and are more willing to take risks. And so their motivation to take risks come from their desire for independence, and their brains are hardwired and more sensitive to these increased rewards that they feel from engaging in these new and risky experiences with uncertain outcomes. And so risks can be positive, and risk-taking and reward-seeking can be leveraged to encourage health protective behavior. And so very young adolescents are also experiencing many changes in their social world. So as they're changing physically, their social world also changes in response. So many young people are usually experiencing one or more social transitions during this time. And as they begin to look more like men and women, they're also increasingly seen as sexual beings by adults and peers. And this can change the expectations and roles that others have for them. And so the outcome of these changes are culturally specific. So, for example, in some cultures, boys and girls have increased freedom and independence during this time, while in others, girls might experience significant restrictions. And so in some contexts, young people begin to spend more time outside of their family structure, hanging out more with friends, socializing more with other young people. But regardless of the context or culture, positive relationships with peers and trusted adults are important parts of healthy development. And so the interaction of all these lead VYAs to also experience changes in their identity. And one of the main tasks of early adolescence is for young people to figure out who they are and who they want to be in the world, and to develop an identity that's separate and independent from their parents as they prepare for adulthood. The changes that are occurring in the brain contribute to identity formation as young people become more sensitive to positive and negative feedback they receive from the people around them. They are very sensitive to social evaluation of things that they can change, such as what rules they want to follow, what they want to eat, who they want to spend time with, and maybe what clothes or hairstyle they want to wear, and how much effort they want to put into their homework. And also about things they might not be able to change, such as their gender, race, or economic status. And so developmental science has identified that certain types of learning, especially those associated with feelings and emotions, which are more salient during this time, happen more easily during early adolescence compared to other times during the life course. And emotions can affect learning and future motivation to engage in certain behavior. So learning and failure often cause negative emotions, and very young adolescents usually need support to learn how to name and process these emotions associated with learning, these learning experiences, so they can decide if it makes sense to try again and master that task, or to let that task go and try something new. And learning can also cause a lot of positive emotions. And when it does, it's also equally important for very young adolescents to spend time reflecting on those positive feelings so they know how to recreate them for themselves. And so the feelings that young people have in response to social feedback informs the learning that they leverage as they test out their new identities, and that will shape their future paths and decisions. And so we've talked a bit about how this affects sexual reproductive health and gender outcomes. And so the physical process and maturation combined with the new feelings of sexual attraction and motivations to engage in romantic and social relationships and sexual behavior makes this an important time for learning that leads to positive behavioral outcomes, which can influence adolescent sexual reproductive health throughout the life course. And this is also a period of increasingly gendered experiences and expectations. And so this creates an opportunity to foster more gender equitable attitudes, behaviors, and norms before they become more firmly entrenched. And so in the next slide, Vincent will introduce the developmental science considerations we've developed to guide programming based on how to leverage these key inflection points during very early adolescence. Over to you, Vincent.
Sure. Thank you very much, Christine. So just leveraging on the inflection points happening during very young adolescence, we have these 6 considerations to look at. But just for our presentation today, we are just going to discuss consideration number 4, which is the aspect on leveraging the differences in pubertal timing in boys and in girls. So the background of the rationale to this particular consideration out of the 6 is that number 1, early adolescence, like my colleague Elia alluded to, is a great opportunity which presents a chance to counter gender norms. Why? Because firstly, girls grow faster as far as pubertal development is concerned compared to their same age boys. So as boys and girls work together in teams, girls with girls who are more mature and who look physically big and stronger than their same age boys, this helps the boys, or it helps both genders to counter these divisive gender norms. So this is one advantage of this particular consideration. The other one is that it gives both genders the emotional experience that girls can actually be competent and they are actually effective leaders. There is another advantage to this. It influences young people's attitudes and beliefs about gender norms and gender roles. And it also builds young people's confidence and the skill to communicate with the opposite sex. Now, the aspect of having the young people with the ability to communicate with the opposite sex also helps them to reduce some of the social messages about gender inequality. So you see that the background first, the rationale to this particular consideration is firstly that girls grow, as far as pubertal development is concerned, they grow faster and bigger. And as a result of that, it's important that we try to see how we can engage in mixed gender activities with boys and girls because of the advantages that this particular exercise provides that I just mentioned out. Secondly, there's also one very important aspect to this, which is the aspect of parents, ensuring that parents and teachers actually are trained well and because they play an important role in modeling positive gender norms and behavior. Then when it comes to applying this particular consideration, I'll give you an example from the Discover Learning project that my colleague mentioned, Christine, when she just started. We engaged in a mixed gender activity. So this activity was where boys and girls were asked to participate in a relay race. So they were supposed to accomplish a series of obstacles. And these obstacles, they had to accomplish them individually, or they would do them in pairs or as mixed gender teams. So again, these obstacles were picked from those games that are played in the community predominantly by boys and girls. So during the activity itself, because of the mix of boys, what was termed as boys' activities or girls' activities, during the implementation of the activity, girls felt intimidated by what they considered as boys' activities. And the boys also felt, wow, this is a girls' activity. So they were kind of hesitant to participate in that activity. So the facilitators came in to address this by supporting these very young adolescents to express these fears in terms of their hesitation to participate and just to express any other fears they had with the activity. So with that facilitated role with the facilitator helping the very young adolescents express their fears, what happened in the end is that adolescents were comfortable and they were able to participate in the activities. And some ended up saying they were happy that they succeeded in the activities, and others were happy to even try out the same activities. So the lesson with that particular example I've given you in terms of having a mixed gender activity is that tasks that are outside of adolescent gender roles allow them to expand their understanding of gender roles and gender behavior. So as far as application is concerned, we also looked at the aspect of ensuring that culturally, does the context allow for this? As you want to apply this particular consideration, you want to see that culturally, the context allows for you to actually do this, right? Then also ensure that there's training that is provided for teachers, for supporters, parents, or any other adults that are influential to help promote this gender equity in this particular activity. So this is the consideration we wanted to share today. And
oh no, I'm not sure if Vincent was having some internet issues a bit earlier.
I think I'm okay. I can hear you. Yes, I'm okay.
Okay.
Okay. Thank you. So quickly, we have 7 minutes to the end of our presentation. I was just trying to summarize that this is a consideration we have that we can look at out of the 6 considerations that we have. The rationale given and how to actually apply it with an example. So the question we have as we move into our Q&A is with developmental science, do you see value in this particular consideration? and it's possible that this consideration, you may have applied it before in your programs, or is there anything new that you have seen in this, or does this reaffirm anything that you are already doing in your program, or there is something new, or any other questions? We are happy to respond to those. And I don't know, Christine, if we have any questions from the link on the posted Google link, if we did post it.
Let me take a look. So feel free to add questions at any time, even after the session, if you want to hold on to the link. But as Vincent was saying, these are insights that you may already intuitively apply in your work. And so if this reaffirms what you're already doing in your programs, if it adds value, if it adds something new, we'd like to hear what your comments are and feedback. It will only help us improve this developmental science resource that we're creating. Anne has a question. Principles were helpful. Are these available anywhere formally to serve as a guide during conception? So we're finalizing this developmental science guide with Save the Children, and it should be available to readily available once it's finalized, and hopefully in the next few months or so. So we'll be happy to share it with the conference leaders to disseminate. Any other comments or questions on any part of the presentation? I know we gave a lot of information and maybe went a little fast.
So there's a question I've seen here from Miriam. Given what you know about VYA, what would you highlight as unique opportunities with this group versus older adolescents? I think, Christine, would you take this question from Miriam?
Sure. This is also a great question, because there's a question in the Google Doc that's asking if this can be adapted to older adolescents. And we work mostly with very young adolescents. So this is the age group, maybe 9, 10, 11, 12, like right before before puberty. And so there are some slightly different developmental processes happening between very young adolescents and older adolescents. And so I think the unique opportunity with VYAs is that it's a good opportunity to kind of, those inflection points we mentioned, to kind of divert those to create positive health behaviors during that time. And because a lot of interventions focus on older adolescents, and that's usually when risks have already occurred and we're mostly kind of mitigating those risks or like trying to reverse those risks. And so VYAs are really that window of opportunity. And Amal, I'll get back to your question a bit. I think this might be one that we'll get in touch with you individually about on older adolescents. So Claire, in our experience, VYAs are much more enthusiastic and willing to engage with information about childcare. They're also massively responsive to praise and recognition by adults. Yes, they really are like sensitive to that social evaluation, and they like the feedback that reinforces what kind of behaviors they should engage in. And Vincent Kagonia, how can the observations on developmental science be adapted for sexuality, sex education, and a formal education system in a developing context? That's a very good question, Vincent. We're trying to figure that out also in the context of Tanzania, where we are working. And some of these principles are easily applied, I think, in the education context. So it is something that we're also exploring ourselves, and we can definitely keep in touch with that and share any insights we might learn from our project once we finish. And Vincent, feel free to jump in if you have anything else to add.
Sure. I just want to say we have about a minute or so to end. I see there's a comment. Is it a question from Claire? Mm-hmm. The 10 to 14-year-old group are the best age group to work with on health education when your objective is to mobilize children, I believe, as health activists, which is mobilized. So thank you very much. You are actually right, Claire. Thank you for that comment. And I think somehow it also responds to the question that came from Vincent. But like Christine is saying, we are still open also to have conversations. That's why we've put our emails at the end, so you can email any one of us and we'll be able to engage. And we'll be happy to also share the finalized version of the developmental science guide that is being finalized, that can be shared with everybody else for reference. And we'll be happy to hear, if anything, for the chance to hear your experiences on any other considerations that you pick out of the 6. Just for this session, we just discussed the 4th one, and I know there is a lot of other experiences we can get from the others as well. Christine?
Thank you. So,
sure, and I think this is where our time. Yes, Christine.
Yeah, I think we have two more minutes. Is it? I think we stop at 10 to the hour. And so thank you, Angela, for answering, Vincent. And we didn't highlight that the principles are content agnostic. We are explaining the how to deliver the content and not what the content is. So hopefully that it can be easily applied to any type of programming. And thank you. Vincent also has a great comment about scalability, for sure. And thank you, Jayla, for your comment. And thank you, everyone. And this was really great to get your feedback and to hear what you think. Thank you, Vincent.
All right, thank you very much. I think this is where we end our presentation. We'll be glad to get your feedback. Thank you, everybody.
Thank you. So, hello, everyone. My name is Carolyn Grant. I sit on CARE's Health Equity and Rights team, where I serve as the project director for Imagine, the project we'll be sharing more about with you today. And I am joined by my colleague, Ann Latera, who leads the learning and evaluation for this project. And so today, I'll primarily be presenting, but Ann's available to help answer questions as well. And I will focus on sharing some of the results from our formative research and details on the human-centered design process we employed in this project, which provided both a more in-depth understanding of the unique needs of married adolescents, the target population for this project, and allowed for their direct participation in designing the intervention components. I'll then turn to sharing the details of the resulting intervention package that we are testing and the suite of tools that are available for future use and adaptation by those seeking to tackle similar challenges in their own programming. So let me start with just a brief overview and some background basics on the Imagine project. The project was really born out of an opportunity and in response to the challenge that despite the fact that 90% of adolescent pregnancies in the Global South occur among married girls, sexual and reproductive health and other development initiatives have often failed to reach this key population. And this really offered an opportunity to better tailor programming to address their unmet and specific needs. And so in response to this, we set out to design and test a holistic intervention package that could support the healthy timing of first births among married adolescent girls and support the girls' pursuit of other aspirations, desires, and opportunities. This project is ongoing in Zinder, Niger, and Rangpur, Bangladesh. And just a note that this work is made possible by generous funding from the Bill and Melinda Gates Foundation and the critical partnerships with the organizations that you see listed here. So first, to share a bit about our research and design process. We conducted fairly rigorous qualitative formative research with adolescents and stakeholders in their lives, including husbands, parents, mother-in-laws, health workers, and other community members, to understand both the barriers and facilitators the girls face when attempting to plan for and time their first pregnancies. We also undertook a market and opportunity analysis to identify alternative opportunities that were available to and valued by married adolescent girls and would perhaps persuade or support their families and community members to support them in delaying childbearing if that was their desire. This research was then fed into a design process and informed the intervention activities that we would ultimately prototype, implement, and test, and a bit more on that in a moment. But first, moving on to our formative research findings. While we don't have time to cover all of our findings in depth, I'll highlight a few key barriers and opportunities that were particularly salient and that we tried to specifically address during our intervention design process. So first, in Niger, girls had particularly low literacy and education levels, and few girls voiced a belief in their ability to make or act on their own decisions or pursue alternatives to early motherhood. While they were more likely to know of family planning methods than girls in Bangladesh, they still harbored a lot of misinformation and misconceptions. Health service providers were themselves not immune to these misconceptions and were often not well equipped or trained to deliver adolescent-friendly sexual and reproductive health services. There were strongly held expectations in the community that adolescents give birth within the first 2 years of marriage. And if she did not, both her and her husband and their family would face stigma. And finally, husbands really control all decisions. And while this was also true in Bangladesh, the power husbands held over girls' lives was particularly acute, with mother-in-laws and mothers deferring to the husband. We also identified opportunities to leverage and build upon. These included that most respondents acknowledged that delaying birth could be beneficial for the health and development of mother and child. There was well-established support in the communities already for spacing after first birth. And many agreed that delaying a first birth so that girls could contribute economically to the stability of the family would be a positive. Turning to Bangladesh, many of the barriers were similar to those in Niger, but there were a few that were specific to the context that we designed around. For instance, girls were more socially isolated and there were stricter limits on their mobility. This, combined with the fact that healthcare workers did not see adolescent girls as a target population and so did not make home visits, meant their access to reproductive health services was very limited. And this likely manifested in the lower knowledge of family planning methods that we observed. Respondents saw childbearing as a means for girls to increase their social status and autonomy within the family, but there was some recognition that continuing education or economic pursuits may be an acceptable reason to delay childbearing. And finally, unlike in Niger, an adolescent girl's mother-in-law was very influential in decision-making. In many cases, a young couple would report that they would agree to use family planning, but felt pressure from the mother-in-law to cement their marriage with an early childbirth. As I mentioned, with our formative research and market results in hand, we embarked on a human-centered design process to identify potential intervention solutions that address the identified challenges and leveraged opportunities. We then developed rough prototypes of intervention materials and activities and tested them in the community to gather feedback from participants. And you can see some of the components we tested in each country here. In Niger, this included an interactive game to illustrate the way choices and decisions may impact a family's ability to provide a healthy and prosperous future, which was a desire young men really articulated during the formative and design phases, as well as a debate activity and family budgeting exercise with husbands, as these were skills the men identified as valuable to them, skills they really wanted to build. In Bangladesh, prototyping included a newlywed kit that included family planning information and activities like conversation cards for the couples, as well as a visioning and goal setting exercise to support couples' communication and joint decision-making. And just to know, in deciding what components to test and prototype and ultimately which to keep in the final design, we considered 4 main criteria. Was the activity acceptable and relevant? Did it have the potential to be transformative as well as scalable? And was it feasible within the constraints of our project, mainly considering things such as timeline and resources? So this design process led us to 2 holistic intervention packages, each tailored to their context. The girls' collectives formed the foundational component in both countries, and these are girls' groups which serve as a platform for delivering a curriculum that covers a variety of reproductive health topics, gender and social norms, and life skills like planning for the future and communication and negotiation. We also incorporated or layered onto this core curriculum financial literacy and business entrepreneurship skills to prepare adolescents to engage in vocational trainings and income generating activities, as this was the main alternative pursuit that was identified as acceptable and appealing to girls and their families. The groups also serve to build girls' social support and tackle the challenge of social isolation that we identified, and have served as a platform for facilitating health worker visits during key family planning sessions. And so really to help establish as well a girls' connection to the health system and thus addressing that major barrier that girls faced. For vocational training, we teamed up with public and private partners to match girls with vocational training opportunities that were identified as promising sectors in our market research. In Niger, this included working with the Ministry of Agriculture to deliver training in livestock fattening, cowpea processing, and feed fodder production. We also supported girls to establish youth savings and loans groups as a resource to draw upon in executing their businesses. In Bangladesh, this included training in jute and cotton handicraft production, working with local and national producer groups and retailers. We're also training a cadre of IT entrepreneurs in skills like web development and graphic design. Here we're working with Coders Trust, a social enterprise that trains women in the IT sector. And we're training in mobile repair and telecom retailing with Robi, one of the largest mobile network operators in Bangladesh. Then to ensure quality family planning services are available, accessible, and acceptable for married adolescents, we developed a curriculum for use with healthcare workers that blends reflective dialogues for the health workers to evaluate and shift potentially harmful norms. And that is paired with skill building and family planning counseling and adolescent and youth-friendly services. And then finally, we knew we had to engage men and the broader community, but approach this in different ways in each context based upon the formative and design insights. In Niger, we worked with existing informal men's social clubs called FADAs to engage young men and husbands. And the groups received a curriculum similar to that of the girls' collectives, but also includes skill building activities that supported their particular needs and interests, such as the financial planning and debate skills for engaging in community discussions that I mentioned. We also conducted dialogues at the community level using CARE's social analysis and action approach to support participants to identify, question, and ultimately commit to shifting or changing norms and behaviors that impede the health and well-being of girls in their communities. And in Bangladesh, our engagement strategy took the form of couples counseling. And these were private, personalized counseling on topics around family planning, communication, negotiation, planning for the future. And some sessions included the mother-in-law, really in response to that influential role she plays to help reduce potential backlash and engage them in the couple's journey. So then to facilitate the delivery of these components, Imagine developed a suite of tools that we wanted to share with you today in order to support other practitioners and programs who may be working with married adolescent girls to help them support them in exercising their right to sexual and reproductive health. Many of these tools are in French and English. Some are in Hausa and Bengali as well. So just to know, all of our intervention components were implemented by trained field facilitators. And on this slide, you can see the 6 curricula that these facilitators use: the Girls Collective Manual, the manual for the FADA groups, the health worker curriculum, as also the Youth Savings and Loans Association Guide that adapts CARE's Village Savings Loans Association approach that is used with adults for use with adolescent girls. The couples counseling guide, and then finally the Prosperous Futures board game that I mentioned earlier. While all of our components were initially implemented by trained field facilitators, we transitioned the running of all groups and activities to peer facilitators, in part in an effort to sustain activities after the close of our project. As we initiated this process, we realized that our curricula was really unusable for many of the FADA and Girl Collective peer facilitators, given the lower literacy levels. So we revised the tools to rely less on lengthy text and more on pictorial explanations and summarized key messages of the topics covered in the full curriculum. And this was really a learning for us because through this process, we realized there's really a dearth of resources and tools for lower literacy audiences. Much of what is available for peer leaders assumes a high literacy level. So really highlights the need for more sharing between projects and how to address this constraint. But we're particularly happy to be able to offer Imagine's tools for others wanting to work with lower literacy audiences. And then finally, we have 2 complementary implementation approaches and tools I wanted to highlight. First, when developing Imagine's GBV risk mitigation strategy, our team found that there were not many tools aimed at preparing non-clinical program staff to recognize and appropriately respond to incidences of gender-based violence. So we developed a do no harm approach that orients staff to the concept of gender-based violence, the principles of psychological first aid, and ensures that they understand both their responsibilities and limitations in addressing and building safe referral skills. And the package includes a training as well as accompanying standard operating procedures and a resource guide. And then finally, as part of our the routine learning for the project, we employed a relatively light adaptive management process that guides implementing staff along with the project participants and critical reflection of what is or is not working, how to course correct. And that really allowed us to tackle implementation issues early and quickly and pivot as necessary. And so wanted to offer that resource as well. I'll conclude by leaving you with links to our project website where you can find published papers on our formative results, briefs on the project and intervention components, as well as all of the tools I covered today. And just to note what is upcoming, we are wrapping up implementation in the next few months, and then we will be conducting both qualitative and quantitative inline evaluations. And we hope to share results towards the end of this year and into 2022. So please keep checking back for updated tools and resources and findings. And my email is here as well. Please reach out to me with any questions, as I do realize we're close to end of time. We still have some folks, although I believe we're almost at the end of time, but if you wanted to include any questions in the chat box, please do so.
I see one question, Carolyn, from Vincent. Vincent, if I might read this, the health worker reflection and skill building intervention tackles provider bias issues that you identified during the formative stage, I suppose. That's correct. How has this positively affected adolescents' ability to access services in your project?
Thank you, Vincent. So after we conducted the reflective dialogue sessions with health providers and the skill building, we did see increases or more commitment to visiting the girls' collective groups and the couples through the couples counseling sessions in Bangladesh. And in Bangladesh in particular, health workers, and this is all anecdotal because, as I said, our evaluation results are forthcoming, but health workers really reported back to project staff a increased recognition in the need to deliver services to and visit married adolescents, and really saw counseling married adolescents is helping them fill their mandate and reach some of their service delivery targets.
And we have
You go ahead.
just one other question, Carolyn, from Julie. How are adolescents involved in developing the different tools and manuals, practically speaking? And Vincent says, thank you.
So practically speaking, CARE developed the tools and manuals, but we did get feedback from the peer leaders and the girls in the groups when we were developing the more image-based manuals. And using them, the peer leaders worked with the field facilitators for a period of time, helping co-facilitate, and gave us some feedback on the tools at that time.
We are getting the signal that unfortunately we're at time, in fact, surpassed time a little bit. So thank you all. Maybe we can follow up with questions directly. Carolyn shared her email here. And of course, you have the resource links provided as well. Thank you so much, everyone.
Great. Thank you, everyone.